Epidural steroid injections are the most commonly performed procedure in pain clinics worldwide. For patients with radicular pain, they are the standard first-line interventional treatment. National guidelines from the American College of Physicians authorize these injections based purely on clinical presentation. No mandate requires a pre-injection MRI confirming structural pathology before a patient receives treatment. But clinical trials follow a different rulebook. The rigorous studies used to determine the efficacy of these injections systematically exclude patients who lack concordant MRI abnormalities. This creates a massive gap in the medical literature. Millions of patients with normal imaging receive invasive epidural injections every year, yet we have almost no empirical data detailing how they actually fare. To address this, researchers conducted a 16-year propensity-matched analysis. The goal was to measure the pain and functional outcomes for patients presenting with classic lumbosacral radicular pain, but whose MRIs were completely normal or near normal. These unique findings reveal a serious blind spot. The medical community has been routinely performing an invasive procedure on a specific patient profile without knowing if the intervention actually works. The experimental group in this study required a very specific clinical presentation: classic lumbosacral radicular pain radiating into the lower leg without any signs of frank structural compression or unequivocal neurological deficits like muscle wasting. To classify an MRI as near normal, strict radiological criteria applied. The threshold was a modified Fearman grade 3 or less at a single disc, without full-thickness annular tears or protruding material. Any diffuse involvement, multiple involved discs, severe degeneration, or stenosis meant immediate exclusion. This cohort represents the truly invisible patient. They carry the burden of undeniable, localized shooting pain, but possess no visible structural culprit for a physician to target. Studying this phenomenon is difficult due to the rarity of these cases. Researchers had to aggregate 16 years of prospective study data to find just 14 valid normal MRI cases who had undergone an epidural steroid injection. To eliminate confounding clinical variables, these 14 individuals were propensity matched against a database of 496 patients who had received the exact same procedure. The matching process isolated tight demographic variables, pairing the cases directly to control patients with an average age near 35 and a mean pain duration between 2.5 and 4.3 years. They then matched the clinical variables, focusing on baseline leg pain intensity, Oswestry Disability Index scores, and the presence of psychiatric comorbidities. This generated a control group of 14 patients. Their clinical presentations were identical, but their MRIs showed concordant abnormal pathology compressing in nerve root. Because the clinical profiles of these two groups are virtually indistinguishable, any divergence in their treatment outcomes is driven entirely by the presence or absence of the MRI pathology itself. This flowchart tracks the outcome trajectory of both the normal and abnormal MRI groups over 12 weeks. At the 4-week mark, there was no statistically significant difference in the mean reduction of leg pain between the matched groups. By 12 weeks, the pain reduction remains statistically identical. The normal MRI group did show a statistically significant improvement in functional Oswestry Disability Index scores, though the absolute difference was small. Looking at this comparative bar chart measuring the categorical overall treatment success at 4 weeks reveals the true paradox in the data. Only 28.57% of the normal MRI group met the strict criteria for a successful outcome, defined as a 2-point decrease in pain coupled with a positive global perceived effect and no additional interventions. Compare that to the success rate of the massive 496-patient clinical cohort from which the controls were originally drawn, which sat at nearly 57%. While patients with normal MRIs fare no worse than their tightly matched subset of controls, having a mild imaging profile yields a lower injection success rate when compared to broader clinical populations. Why do patients with less visible damage respond so poorly compared to the general population? In the absence of frank compression, the standard pathophysiological explanation for radicular pain is chemical irritation. Inside a degenerated disc, elevated inflammatory cytokines like TNF-alpha and interleukin-6 extravasate through full-thickness annular tears. They physically bathe and sensitize the dorsal root ganglion, creating radiating pain. Now look at the anatomical reality of the normal MRI group. Without significant degeneration and a full-thickness annular tear, there is no physical avenue for those chemicals to leak out. If there is no anatomical pathway for inflammatory mediators to reach the nerve, the localized physical target for an epidural steroid theoretically does not exist. If there is no structural compression and no physical pathway for a chemical leak, why do roughly 28% of these patients still achieve a positive outcome? The authors hypothesize that for this specific cohort, the mechanism is driven by central sensitization and somatization. Central sensitization can massively amplify normal sensory signals. The central nervous system effectively creates severe pain without relying on local organic pathology. This aligns with the data. A 28% success rate closely mirrors the efficacy rates reported for sham procedures and placebo responses throughout interventional pain literature. The pharmacological timeline is also telling. The physiological anti-inflammatory effects of epidural corticosteroids rarely exceed 6 to 8 weeks. Yet, the responder rate for the normal MRI group did not decline between weeks 4 and 12. This suggests differences in the natural history of the condition, or a pure placebo response, rather than ongoing medication efficacy. The lack of physical pathology, combined with a steady, low-tier response rate, points towards psychological and systemic drivers of pain relief, rather than a localized steroidal mechanism. Treating normal MRI radicular pain with epidural injections is fully authorized by guidelines, yet the mechanics of why it would work remain poorly understood. The data shows that while a fraction of patients with near-normal MRIs will benefit from an injection, their overall efficacy rate is severely depressed compared to historical controls. This undermines the intuitive clinical assumption that milder structural issues on an MRI should translate to an easier or more successful injection outcome. Clinicians should factor in this higher probability of poor outcomes when recommending injections for radiculopathy without concordant imaging. For these patients, the diagnostic focus should shift away from repeated local spinal injections and move toward identifying and treating central sensitization. In the absence of a visible radiological target, the success of an epidural steroid injection likely relies far more on the neurological power of the procedure itself than the medication inside the needle.